Welcome to the Psychiatrist Waiting Room, a show where I interview my dad, a psychiatrist with 55 years experience, all about mental illness. The aim to explain mental illness as simply as possible. Good morning, Dad.
Good morning, Georgia.
I thought I'd start with asking you about the biggest change you've seen in your 55 years in medical practice, 48 years as a psychiatrist.
Okay, it started before my time, which is medications. And that was in the medications that actually did make a difference, I should say. In the 1950s, when they introduced antipsychotics and tricyclic antidepressants, with this medication, you were able to empty out the hospitals, which had 7,000 patients in it. When I started, there was only about 1,500. Now they're all closed down. But in my time, the big change from that was Prozac and olanzapine, which again were an antidepressant and an antipsychotic. And that changed the whole face of treatment. We could throw in there also Viagra, so that really removed sexual dysfunction from psychiatrist to medical. Mm-hmm. That really made a lot of difference. And so you really, all in our sexual dysfunctions goes to the urologist or sex therapist. But so medications have been the main reason, and they're the two big times. But in my time, when Prozac came out, it was just amazing.
Changed
conditions that you couldn't treat before could be treated.
And that was major depressive disorders?
Major depression and anxiety. And so the SSRI drugs, selective serotonin reuptake inhibitors, and Prozac was the first one, were able to treat minor conditions, which before would spend a lot of time in psychological therapies, doing more analytic type therapy, to moving psychological therapy to more cognitive behaviour, because and therefore even psychological therapies changed as a result and focused in a different and more productive way and worked with the medication.
And it got people out of hospitals, both public and private.
Yeah. And improve
freeing
relationships.
Up beds for other people. Yeah,
so they were the big changes. If you're talking about diagnosis or treatments, they're the treatments that I noticed. The diagnoses also changed in their nature. They moved from strange, bizarre, descriptive terms like anarchistic personality.
What's that, anarchistic personality?
That's just an inadequate personality. There's these strange terms. It's just like mental illness. They had, you're either an imbecile or a moron or something like that. Now those terms are replaced by autism or neurologically compromised, and more to do with the medical description rather than caricature of the illness. So the description of people changed as well. And I think that allowed the psychiatric patients to become more acceptable. And
more infiltrated into just normal,
into the general population.
Societal norms. So what about an actual illness? Not the medications changing an illness, but the evolution of a mental illness, which has been the biggest one?
Well, in my lifetime, I suppose bipolar disorder became more complex because they started diagnosing bipolar 2, which then became a little bit more of the opinion of whatever psychiatrist was treating a mild bipolar. I think bipolars became a little bit more difficult. Schizophrenia became much more tighter in the description, and so a lot of the other types of schizophrenia, like hebephrenic schizophrenia and catatonic, disappeared, and it's mainly the paranoid schizophrenia, which always was the difficult one to treat. The others get treated much more better with antidepressants and ECT. Mm-hmm. So there's been a change in the schizophrenias, and they become much more manageable. They have long depot injections and community centres monitoring people so the people can be in the community. That's been another change.
Going back to
and ADHD probably is the acceptance of ADHD as a condition in the last maybe 7 or 8 years has been a great change and a benefit to most people who would have been treated with anxiety tablets rather than ADHD medication.
Just going back to the bipolar disorders, you said that that's become difficult?
For me.
For you personally, why is that? Because
I think it's just that a major bipolar disorder is pretty easy to diagnose,
right.
Bipolar 1. the man in the pub could diagnose it, either the depression or the mania, but episodes. But since they started diagnosing bipolar 2 and the use of antidepressants seems to destabilise bipolar disorder. So treating the depression of ADHD, of bipolar disorder, is with medication like antidepressants seem to make their mood changes much more frequent and difficult to manage. The bipolar ones, I've thought, are still a work in progress.
And that's in terms of getting the medication balance right.
Yes. Yeah.
Now, what else? What the other topic that I really want to discuss, the topic of men and shame. Having worked for you on and off over the years, ever since I was 10 years old, I did notice a pretty consistent presentation of the 40-plus-year-old male who would come in because he'd had a massive life experience or difficulty. That is, relationship breakup, lost money, lost his job. But they would come in and they couldn't look at you in the eye and they would be looking at the floor, waiting to see you. And I remember you saying to me once that any man over 40 that comes to see you like that, you are actually concerned. You get worried. You want to get onto this ASAP. Let's talk about it.
Yes, well, a man in his 40s, and we're talking about well-functioning people, probably married with a wife and a couple of primary school kids, paying off his mortgage. He's in a situation where he's probably just making financial ability for them to just keep their head above water. Then a difficulty will occur, which will result in that male developing low self-esteem. The most likely one is financial struggles, making ends meet. Come straight to the heart of their masculinity. The very purpose of them existing is to provide and be able to look after the family, and therefore they'll develop that low self-esteem, a failure. And they'll develop a shame posture of not being able to keep eye contact because they become aware that the other person can see right through them and see their inadequacies. And when they get like that, they become the opportunity to end the pain is through suicide. You don't want a patient to have a major depressive disorder and financial difficulties. The next one is, of course, if the wife is having an affair, or maybe not having an affair, but he's having sexual difficulties as well. Mm-hmm. And he'll be having sexual difficulties because maybe his age, but more likely to be because he's not doing well, because he's struggling with his job. And he loses his self-esteem, and his member loses its self-esteem as well and doesn't function as well during intimacy. And therefore they feel, again, a lesser person. And if you develop a depressive disorder with that, so it's important to treat the depression and get on top of that with medication and psychological therapy, and probably even couple therapy if you think that's significant.
So what I've noticed is that there is a rut of thinking that these men will get into, and they really believe that the world is better off without them. They really believe that their kids and wife and everyone would be better off without them, and it is...
They've brought shame to the family.
It's the word shame. Now, it's a matter of flicking that switch, because once that switch is flicked, they have an epiphany almost that it doesn't have to be like that. And you want to get that person to flick the damn switch. So how do you do it?
Well, in the assessment, you decide, do they have a mental illness, major depressive disorder? Do they have mental illness that runs in the family, which will tell you about this? And if it has, you treat that and they'll get better. Plus having psychological therapy. The other one is assuming that's not the case, that they're well-functioning people who are in a bad place because of the downturn in the economy, or the fact that their business went broke, or the company they work with did a merger and they were sort of retrenched and having trouble getting another job. The wife's recovering from childbirth and not in a position to be empathic or understanding. He doesn't talk to anyone, doesn't talk to his friends about it.
That's the hardest type, who don't talk to the friends.
That's right. Don't talk to your friends or look for a solution, and you can't do that and you become isolated. And
now that's for the support network to really look at, hey, you're isolated, hey, you're not as vibrant. So that is, again, the importance of the support network, family and friends, if there is someone who they think is a little bit off.
Yeah. Oh, yes, it's very important that they're able to communicate with a significant other.
Is there anything specific you say in therapy to these men that you know will flick the switch?
Oh,
It's not you, it's the illness.
If
It's not you, it's the illness.
if they're severely ill, at risk, you actually may switch and use guilt to get them not to. The other thing I have used, if they're religious, I'll use the religion and talk to them about if they have faith in their religion, is you use that to help the person have someone to talk to, someone to bond to, or even their own Bible, etc., to give them hope.
A form of connection. They need connection.
Yeah, so you look for that where there is. They might say, "Oh, my best friend John," or things like that. Or they like reading a book, and like an alcoholic might go back and read the big book on AA and stuff like that and take some comfort from it. There's various ways that you find out, if you can, is there something that that person values, and then you push them in that direction.
Right, so it's what they value and you push them. So, for example, they go to the cricket or the football. Do you say, get together with your friends and just go to a match? Do you push that kind of thing, or do you...
If that's the case, and they can do that and not be ashamed, that everyone can see that they're not functioning well.
Do you tell them that it's okay to tell other people, friends, family, that they're not feeling good?
Are you okay?
Yeah.
Yes, sometimes I even spell out the letters and say, have you seen this on television? Are you okay? And therefore talk to others, and you're looking for something that's meaningful to that particular individual.
So it's connection, because they just reach a point of massive disconnect.
Yeah. Oh, you get some, I'm just thinking another patient may be thinking of suicide, but they're religious. So you really push, God would not be pleased with you, and what would happen. And they say that reason. Or the other thing is they don't want to harm their family.
Yeah.
To say that that'll keep you alive for your family, keep your family looking good.
Have you seen
You get a purpose. Give them purpose. Give them hope, future, because they can't see hope, future, and purpose. That's the problem.
Yeah, and the shame is not who they are. Have you seen that the conversation out there for men is a lot more open now, because there is Are You Okay? There are numerous groups out there. There's even an organisation for tradesmen to go if the men are feeling depressed. There's...
Yeah, one of my patients has joined a group called the Mongrels.
Oh, what's that?
It's just a group of men who get together and talk, like without a therapist.
That's great.
And
Do they know each other?
And they ring each other up. I don't know how you find who the Mongrels are. You probably Google it.
Love it.
You find the Mongrels anyway. And then you just join it, and you'll find some people in there. Some of the men will be helpful to the other men. What I gather from this, I've only had one experience with a patient going to that group, is that they tend to be maybe tradies or business people who are, isolated and not having any support, but they're supporting each other.
That's really good though.
Yeah.
Yeah, that seems on the increase. That level of connection.
I think these sort of little self-help groups
really
are
work for men.
evolving.
Yeah, love it.
Now I'm going to tell you a little vignette about my theory on why men can get into shame.
Go for it.
Okay. Now, you know how mankind is scared that the machines are going to take over and control us? That the Transformers or the AI,
oh yes,
that the machine is now going to control mankind. Mm-hmm. Well, this all happened once before, at the very beginning of time, and the female is the natural product. The egg is a female, and a sprinkling of testosterone on the egg will make it into a male. So the male is a byproduct. So in actual fact, the female has created the male. Bigger than her and stronger, just like the machines, just like the to do all the hard work, to be a hunter and gatherer, to be a hunter while they at home with the kids. They lift things, build things, do things. So in actual fact, mankind is basically the female is on the nest and the men are doing all the work. They've been created to look after the female. You follow that?
Mm-hmm.
What happened over a period of centuries or time is the man, which is the machine, got powerful and took control of the female.
Ah.
Yes. And how did he do that? He created religion and he put himself at the head of the church or the religion or the mosque or whatever it is in any society, and they got control of women. And already the machine had taken over from the creator of the machine. And women since then have been trying all their life to deal with this. But what this leads to at the beginning of our story is that the man can fail because he's only a creation of the female. And if he hasn't pleased her and done the things he was created to do, which is to look after the family, create a business, make money, he's ashamed. He's failed. That's an ethological explanation of why
your
people...
own theory.
Yeah. I got that idea watching some of those Transformers
movies, the Transformer movies. That's hilarious.
Who were controlling the world. Yeah.
Evolution is matriarchal, religion is patriarchal.
Yes.
And we've been having a bit of a fight ever since.
That's right.
Interesting. Well, Dan, I'm sure we're going to get a few more of your theories down the track. I know you have a few more off your sleeve. Okie dokes.
Okay then.
On that note, we're going to wrap it up. Thank you so much for joining us. If you'd like a question answered, please email me at georgiacassimatis@yahoo.com. See you next time.
Will we be answering that in series 2?
We will.
Okay.
Bye, Dad.